Tell me a little bit about yourself.
Okay, so Christina Dueno. I'm a psychiatric mental health nurse practitioner. I've been practicing in this role for going on 3 years. I went back to school for my advanced degree later in life. I've been a nurse and an RN for over 20 years. In the mental health profession for 7, and then I worked in other areas in healthcare.
What's the difference between the way you approach patient care and how a psychiatrist approaches patient care?
Wow. Technically, on paper, our jobs are exactly the same. We all are doing diagnostic assessments. We are coming up with a treatment plan, ordering medications, and referring out for any additional psychotherapy or additional testing that we might need to have done. But I think the approaches are a little different. The approach of medical school is different than that of nursing school. Nursing school, even though I'm an advanced practice nurse and I have the skills of diagnosing and prescribing medication, my training is very patient-centered, not necessarily disease state-centered, and the other ways that physicians are trained. Most nurses, you're going to find an extremely caring component to the care that we give, and that doesn't mean that doctors are not caring. That's not what I'm trying to say. We're also, I think, most nurse practitioners very probably over thorough. My husband can do an assessment in, let's say, 20 minutes. It's going to take me 30. Just that being extra thorough, spending time with the patient. For myself personally, I give all of my patients eye-to-eye time. So healthcare has turned to where we're looking into screens most of the time when we're forced to do so if we take insurances, so the electronic medical record. It's very difficult in psychiatry to sit and type a note and not give the patient the eye-to-eye contact. So for me personally, I sometimes sacrifice my charting time, but it yields tenfold because I get to see what the patient looks like, how he's responding, and he believes that I've made a connection with him. I was asked to read a book in my graduate program that talked a little bit about the past moral care. Okay, and as you do your study into state hospitals, you understand that before the state hospital per se, there were homes that used the concept of moral care. And it wasn't the technical, or it wasn't the sterile hospital that we would think of now, like a state hospital. These patients would be admitted to settings that are buildings or homes that might be on acres of land that had a farm, and they were expected to be part of the community as much as possible, or to become part of the community as their mental illness maybe progressed or became less symptomatic, or they were less severe in their symptoms. I think there's something to be said about environment. Nurses are huge. There's another difference. Nurses are huge on environment. Florence Nightingale, she talked very much about, in all aspects of medicine, the environment matters. So when I think about the essence of a state hospital today, and you go way back to when moral care came in, the settings were 2 totally different types of settings. The patients would get up, they would be asked to set dishes around the table, they would be asked to clean the dishes, they would make their beds, they might go out and participate in the garden in some way. There was some sort of participation. It wasn't that you were sitting in your room, maybe having some therapy, but most of the day looking at walls or sitting in a main room with other patients. So if I brought back, and by the way, moral care at that time, there wasn't a lot of medication available, and the patients during that time actually did well. Many of them went home. They convalesced in a peaceful setting, in a setting that was healthful. They were getting good nutrition. The meds that could be given at that time were given. And they were allowed to allow the mental illness to run its course. Now, obviously, some people may have ups and downs and, different exacerbations or worsening of symptoms. And some are so chronically ill that they may never eventually come out of a setting like that. But at least we had places like that for those patients. But there definitely was this whole concept of moral care. And if you look at the original setting, which some of these places were in Boston, right?
Mm-hmm.
So if you look at some of our original psych hospitals, they occurred in Boston, Massachusetts, okay,
Mm-hmm.
with McLean Hospital. So there's a lot of pictures that you can find online of what these you can call them hospitals, facilities, what they look like. They look like Downton Abbey minus the castle, but they had grounds like that for the patients to be out on. Rocking chairs on the front porch to sit and catch what? Fresh air. Another one of Florence Nightingale's concept, environment, fresh air, keeping things clean, right? Promote health and promote healing. The concept of the state hospital, I think, was good in its intention, but like everything, there were issues with it. I'm sure there were abuses. It wasn't perfect. But when they made the decision to shut it down, it seems to me it's in our culture, the pendulum swings from one dramatic side to another. We don't seem to be able to make common sense. Okay, let's look and see what about the state hospital is actually helping these people, and what needs to be fixed because it's broken and there's abuses, and how can we fix that? It came to, no, you're stripping these people of their rights, and we need to completely take people out of these hospitals. And that was done without, in my opinion, thinking about what were we going to do with all of those people. What are we going to do with chronically mentally ill patients? Now I can tell you what I've seen in the 3 years that I've practiced an advanced practice nurse, and my time in research where I also worked with some group homes. They end up either A, in a jail system, B, in a nursing home, C, in a shelter, D, in a group home, and group homes are not regulated in our country, so you can have some awesome group homes. I'm not throwing the group home concept out the window, but I'm here to tell you that I've seen group homes where people have actually been taken advantage of, and you would not. The inside of it, the inside of the group home was unbelievable. It was deplorable. So you've got everything from that in between, and then you have them.
Something you have personal experience.
I have personally seen that.
Okay.
And then they live under the bridges or on the sides of the street. I don't even know the percentage, but you could probably look that up, that there's a high percentage of the homeless people that we see around this country that will have a mental health condition. So the question becomes, is that autonomy and the fear that we're going to somehow lock people up, which I think may have occurred in some cases, but certainly wasn't occurring in all cases, in the majority of cases, right? It comes back to looking at what was the problem at the time and how could we have fixed it and made it better, right? Instead of doing away with the whole system. Because now we have a group of people who aren't being taken care of. A lot of the homeless, mentally ill patients get into drugs. So here in Dayton, that is an increase in the drug, that just contributes to the drug problem we already have. Mentally ill patients typically aren't violent people, but they'll use for they're depressed, they'll use if they're anxious, they'll use if they're hearing things, if they're psychotic, hearing things, seeing things, they numb it, they want it to go away. So when we're not able to provide for them a setting where they can have medications, have their needs met, their basic needs met, they resort to other things. So yeah, I'm a proponent that we should bring them back, but that we should bring them back very thoughtfully. If somebody tasked me with, and this is just off the cuff, if somebody tasked me to put something like that together, I would paint color goes a long way. The materials you use, you can find cost-effective materials. Placing it on a property where people can get outside. People need to be outside, not locked into a building for 6 months, a year, however long they need to be there. So I think that's important, and we need staff who have a heart to serve the mentally ill. So many people get into psychiatry because it pays well these days because there's a shortage, but they don't necessarily have the heart to deal with a mentally ill patient. And I think that you saw some of that back in the in the state hospital model. There were people who were there, they were qualified professionally to be there, but they really should not have been there taking care of the mentally ill patient because they just weren't suited.
Do you think that there's like a shortage of mental health nurses or a shortage of qualified mental health nurses?
Yes, and there's a shortage of psychiatrists. So psychiatrists are like dinosaurs these days. I mean, especially here in the Dayton area. Psychiatric nurse practitioners are in high demand, and many nurse practitioners are switching specialties because of the pay. The pay as well for what we do, because there's a shortage, and that bothers me because I'm afraid people will jump ship and want to practice be a psychiatric nurse mental health practitioner for the money and not for the love and the calling. For many of us, it's truly a calling or a desire to work with this population. You have to care. You have to have a caring heart, and you have to learn to listen. Many other specialties in medicine, whether it's physician or nurse, you are actively doing something. So it looks, you're doing your thing, and maybe you're listening, right? Active listening, where you're engaged in what your patient is telling you, versus as you're doing something and the patient thinks you're listening, but you're thinking of 10 different things. In this job, you have to actively listen and connect, develop that therapeutic relationship with people. Insurance companies make our job extremely difficult. Reimbursement rates, they've cut them low. They believe that mental health is where they can make their cuts. And so we've learned to work in that environment, which is challenging sometimes. So some of the patients can't even get a hold of medications. The insurance company will come in and say, no, they can't have that one. They need to try X, Y, or Z first, and then they can try that one. So we fight it. We fight it on different levels. As to why they don't spend more money on mental health, well, we have a huge deficit, and we spend money on health care in general, but that doesn't necessarily include mental health. We have, for example, they're wanting to spend more money now on the military. So there's just it's not a priority for people. It doesn't touch everyone's lives. And so to say I want to spend X, Y, or Z on a program, it doesn't necessarily gather the support that it needs to move forward.
Do you have like a certain outlook for whether or not this is going to improve in the future?
I think so. I'm hopeful. If not, I wouldn't be doing what I'm doing. If someone hears this and realizes that there's more of us out there that work in this profession who love our patients but feel that there is a need and a place at certain times in certain patients' lives to benefit from reopening state hospitals, then I'm glad to go on the record doing that. And maybe even if my life wasn't so crazy, be more of an activist for it. Because what we're doing right now is not working. At the hospital setting, we will get the same patient who's homeless back in every 30 days, completely decompensated, because he didn't go and follow up with the community mental health center, which is our model, right? You leave the hospital and we get you hooked up into the community health center. They don't go. They just don't go. And then they come back to the hospital. We stabilize them. We give them a long-acting injectable, which some people don't even, there's people who think that's even not a great thing. But it keeps them stable for a month at least and not decompensated. So it's a revolving door. And we just put a Band-Aid on it. They come in, Band-Aid, Band-Aid, Band-Aid. And we know that patient is going to be back in. You get to know them. That's how sad that is. You get to know them. And then one day sometimes they don't come in, and sometimes it's because they found a community mental health center, and sometimes it's because you find them in the obituary column. So yeah,